Welcome to A&A Investigates, a monthly podcast featuring the latest in neurology and neuroscience brought to you by the American Neurological Association. I'm your host, Adeline Goss. For much of the history of neurology, diagnosing a genetic disease meant giving bad news. Genetic meant incurable, often fatal. On past shows, we've talked about how this narrative is changing for certain monogenic diseases like Huntington's disease, where emerging gene therapies offer hope for a cure. But what hope can the field of neurogenetics offer to patients with more complex diseases with both genetic and environmental risk factors, diseases like Alzheimer's? My guest today, Dr. M. Elizabeth Ross, is professor of neurology and neuroscience and director of the Center of Neurogenetics at Weill Cornell Medicine. Her lab works on the genetics of neurologic diseases affecting humans at every stage of the life cycle. Today, she'll help us understand the role of genetics in a range of neurodegenerative diseases and how and when clinicians should incorporate genetic considerations into patient care. Dr. Ross, it's great to have you here on A&A Investigates. Thank you so much for speaking with us today.
Delighted to be here. Thank you for the invitation.
So, Dr. Ross, let's start simple. We know that certain neurodegenerative diseases are caused by a single genetic mutation, while others are caused by a complex cascade of genetic and environmental factors. And I'd like to focus on monogenic diseases first. Can you review some of the new approaches to treating these monogenic neurologic diseases?
Treatment depends on the gene involved, how that gene is processed. Are there other genes that are highly similar that could be co-opted to perform that lost function of the impaired gene? Or what pathways does the affected gene product function in? And are there ways of tweaking the process and circumventing that problem? Examples include pharmacologic manipulation of the pathway in which the mutated gene works. For example, a new kinase inhibitor in the RAS pathway to treat plexiform neurofibromatosis, or inhibitors of the mTOR pathway for tuberous sclerosis. Antisense oligonucleotides have been really powerful for treatment of conditions like spinal muscular atrophy. A mutation in the SMN1 gene leads to the disorder, but one can co-opt a related SMN2 gene to make a full-length protein to restore the defect. Or Duchenne muscular dystrophy. It's possible to skip exon 51 in this very large gene and make a shorter but still functional dystrophin protein. But it depends on knowledge of the molecular defect, and a lot of study goes into each of these disorders. Cell transplantation is on the horizon for Parkinson's disease, and clinical trials are about to begin. This strategy uses reprogrammed cells to differentiate toward dopaminergic cells and neurons. Gene therapy can provide a functional copy of a missing gene, for example, in SMA, which is another therapeutic strategy that's coming up. But here again, studies are under investigation.
Great. And your lab, I know, has also tackled some of the more genetically complex adult onset conditions like Alzheimer's and multiple sclerosis. So to start basic here, can you explain how is it that genetic changes can be silent through childhood and much of adulthood and then emerge as a clinically evident neurologic disease later in life?
Well, that can happen both with a monogenic disorder or with complex genetic disorders. In the case of a single gene disorder due to a defect in something like Huntington's disease or frontotemporal lobe dementia with the C9orf72 gene, the late onset occurs because the genetic alteration creates a problem in something like energy generation or difficulty with clearance of some byproduct of metabolism that stresses neural cells over many years. But in other neurodegenerative disorders, it's clear that one gene alteration alone is not enough to cause disease, but a cumulative effect of mutations in multiple genes is required, or in a perfect storm of genetic predisposition coupled with an environmental exposure or a second somatic mutation is needed. In either case, the disease process likely begins years, even decades, before signs and symptoms are recognized and the patient comes to clinical attention.
And how can learning about the genetic component of these more complex conditions help us find treatments that work for these patients?
Well, only 15% of cases of Parkinson's, for example, are monogenic. But by studying the responsible genes, we learn more about the molecular pathways that can cause Parkinson's. Similarly, inherited early onset Alzheimer's disease makes up a relatively small proportion of cases. But we've learned a great deal from the identification of those genes with a high degree of penetrance. That is, if the mutation is present, the disease is highly likely to occur by a certain age. For example, in Alzheimer's disease, there's likely impairment of processing of amyloid precursor protein into A beta peptides. There may be phosphorylation and deposition of tau, a microtubule binding protein. And we've learned a lot about the participation of neuroinflammation and oxidative stress on neurons. But it's important to remember that there's a difference between an inherited disorder and a familial predisposition. In the example of late-onset Alzheimer's disease, there's a complex interplay of genes that confer risk that's coupled with non-genetic or epigenetic factors that we're just beginning to unravel. As we're learning more about the process involved in harming or damaging neurons, and as we learn more about the aspects that start early, years before symptoms actually arise, that gives us an opportunity to find ways to intervene in the process and greatly prolong or entirely prevent the onset of symptoms.
Yeah, and I think that really motivates clinicians to try to identify patients who may have genetic conditions, including those where that discovery may be surprising. And as a clinician, I feel like I've been taught to use certain factors like young age of disease onset or a patient's family history to determine the need for genetic testing. But I worry that this approach doesn't necessarily help me identify patients with spontaneous mutations. So let's say I'm evaluating a typical patient with dementia. What are some of the clues in the history or the exam that should trigger a genetic workup? Is there a set of questions I should be asking of all of my patients with dementia?
Well, first and foremost is trying to understand the family history in considerable detail. It's important to remember that it's not enough to ask someone if there's anyone in the family with symptoms like the patient before you. One has to begin with asking how specific family members are your grandparents or parents living? Do you know at what age your mother or grandfather passed away, and what conditions did they have? Tremor, memory difficulties, difficulty walking, clumsiness. It's not unusual to find that a patient may think that conditions within their family are unrelated to their problems, but actually they may be quite relevant to a possible constellation of features for the patient's disorder. For a de novo mutation, one that spontaneously arose in the patient, that or may be rather difficult to discern, or many times the patient may have only partial family information, or first-degree relatives may have passed away before an age when symptoms would be expected to occur. Then it's necessary to rely on clinical information alone. Knowing that there are genetic causes for Parkinson's or memory problems or MS may prompt a genetic evaluation. So my advice is usually, if you think of it, don't hesitate to refer a patient to a neurogeneticist for consultation.
Great. And as more of these genetic conditions become treatable, like we were previously discussing, I think more people will be tested for them. What are some of the ethical considerations that you're anticipating in expanding genetic testing for neurodegenerative diseases in particular?
Well, predictive testing for someone who has a family member with a neurological disorder, but they themselves are asymptomatic, is a really important topic. It's critically important for the asymptomatic patient to consider what their motivation is to test. Many patients will think that they'll be tested and nothing will be found and it'll be reassuring, but they need to be aware that a monogenic cause of their neurological problems could be found, and that may have ripple effects that they should consider ahead of time. On the other hand, if the patient is of childbearing age, knowing whether he or she has a dominant neurodegenerative gene could make it possible to use prenatal diagnosis to ensure that the gene is not passed on to subsequent children, using in vitro fertilization with pre-implantation genetic diagnosis. And that is often a motivator for wanting to have genetic testing. Knowledge that one has the gene may allow for participation in clinical trials or to plan for legal guardianship and details of care. So it's important for individuals to think about what they're going to do with the information should it come back positive.
Can you remind us of some of the legal implications for patients who pursue genetic testing?
Well, we've had legal protection against genetic discrimination in federal law since 2008. It's called GINA, or the Genetic Information Non-Discrimination Act. And GINA provides protection against discrimination in the workplace, as well as preventing insurers from denying health insurance because of a genetic predisposition. GINA covers health insurance, but not life insurance and not long-term disability. So when being tested for something like that, it may be important to first make sure that the individual has life insurance or long-term disability insurance before being tested.
And a lot of what we've been talking about is a scenario in which a patient is approaching the idea of genetic testing after a discussion with a clinician. But there are now commercially or even recreationally available tests for certain genes that predispose to neurodegenerative conditions like Alzheimer's. How do you counsel patients who may have taken one of those tests and tested positive?
Commercial genetic testing is something that actually is quite interesting and fun, but they're very limited in scope and they're not as predictive as one might think. So, for example, with ApoE4, simply having an ApoE4 allele does not guarantee that one is destined to suffer from late onset dementia. It's more involved than simply getting back one or two markers from a test that's limited in scope. There are many other types of variants that go into the equation. One should keep in mind that what we're working on these days to be able to look at prognosis and risk assessment requires something called a polygenic risk score to be able to look at multiple markers. For example, for MS, there are over 200 genetic variations that have been associated with a risk for this demyelinating disease. And, understanding how those patterns figure into susceptibility and prognosis requires expertise.
You mentioned polygenic risk scores. How is the use of these scores influencing clinical practice now?
Well, we're still at the stage of trying to understand the utility of polygenic risk scores, and they've certainly been used quite successfully now in oncology to be able to guide therapy. But we're going to be able to do that in neurology as well. In MS, where there are over 200 variants in the genome that have been associated with risk for MS, with careful phenotyping, as we learn more about the MR patterns on imaging of plaques, combining that kind of information with a polygenic risk score, we'll be able to understand better what the likely trajectory for an individual patient is, and that can help guide therapy.
So just a final question for the junior investigators listening to this podcast, Dr. Ross, I wonder what corners of neurogenetics are most ripe for future research?
Oh, that's such an exciting question. This is an incredibly exciting time in neurology and psychiatry. For complex genetic disorders, finding biomarkers and clinical phenotypes coupled with these polygenic risk scores will soon make it possible to more finely tune our understanding of individual predisposition. And shortly behind that will come ways to prevent disease. We're going to learn more and more about epigenetics and the environment, the impact that the environment has on our genetic predispositions. And there'll be opportunities for prevention, regeneration, and repair of neurological damage. Something that will affect every single one of us is pharmacogenomics, to have our genetic information help guide understanding how we metabolize medications and help clinicians prioritize prescribing to avoid untoward side effects and optimize the efficacy of the drugs that we have available for individual patients. We're coming to appreciate the contributions of the microbiome to neurological diseases, and this is likely to be enormously influential in how we manage our patients going forward.
Really cutting edge stuff here. Thank you so much, Dr. Ross, for joining us.
Thank you for having me.
That was Dr. M. Elizabeth Ross, Professor of Neurology and Director of the Center for Neurogenetics at Weill Cornell Medicine. To hear more episodes of ANA Investigates or to submit your ideas for future shows, visit myana.org and click on the Education tab. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association, and an ANA Education Innovation Subcommittee production. Thanks for joining us. To learn more about today's program and to find out about the benefits available to ANA members, including access to an array of educational programs and resources, please visit myana.org. Dr. Adeline Goss is our host and the executive producer of the show. Episode producers are members of the ANA Education Innovation Subcommittee, chaired by Drs. Megan Ritchie and Romer Giaccaden. This is your logistics coordinator, Jen Hurley. Copyright, the American Neurological Association.